Health and Human Services Committee meeting. I am Maria Ortiz. I'm the co-chair of this committee. My co-chair is Joe Restuccia. I don't think he's on yet, but he will be here very shortly, very soon. This is our monthly meeting, and today is the first time we're doing it the first Thursday of the month. So moving forward from now on, it's going to be the first Thursday of the month, our committee meetings. This meeting is being recorded and it's currently live streaming on YouTube, and it will be accessible thereafter. If you are not part of the CB4 listserv, please sign up to do that. You can get e-blasts, things that are happening in the community, the agenda, links to documents before the meetings. And let me take a look at the attendees list. All right. All right. Hello to all of you that I do know who are joining this meeting. If this is your first time joining the meeting, I'm not sure if it is. If it is, basically what happens is we'll hear the presentation, then the committee is going to ask questions and make comments, and then members of the public or the attendees get the opportunity. If you do want to speak, just raise your hand. It should be on the bottom of the screen. And after the attendees speak and make their comments or have questions that get answered, the discussion goes back to the committee for the business session. And then sometimes what we do is we vote to write a resolution, which then goes before the next full board meeting for a vote. And let's begin with self-introductions, starting with, I'm going to go by the squares on my screen. If you could say what other committee you're on, and if you're, you know, the deal. Travis?
Travis Rogers, a public member of the Health and Human Services Committee. No other committees.
Yes, because he's a public member of Housing, Health, and Human Services. Hector?
Evening, everybody. Hector Vasquez, and I'm also on the Land Use Committee, as well as this one. Welcome.
Yadira?
Hello, everyone. Yadira Jimenez, and also a member of the Clinton Hell's Kitchen Land Use Committee.
JD?
Hey, good evening. Jean Danielle, member of the Hell's Kitchen Land Use Committee.
Roberta?
Good evening, Roberta, member of the committee, as well as the Waterfront Parks and Environment Committee.
Betty?
Member of this committee plus the Chelsea Land Use Committee.
Paul?
Hi, Paul Ames, public member of this committee alone. Good evening.
Katie, you're up.
Maria, do you need some water or something? Good luck. Good. So hello, I am on this committee, and I'm also on the co-chair of the bylaws task force, and I serve on the Arts, Culture, and Education Committee.
Sabrina?
Hey, Sabrina here. My dog is being obnoxious. I'm also part of ACE's Arts and Culture and Education Committee.
Oh, I guess I should mention I'm also on ACES. Yadira?
You called on me, but
Oh, I did?
I
apologize. Pete.
Stuck in this tunnel, I just got out. I'm here. How are you? Community
Pete.
board member.
Uh-huh.
Yeah.
And what's the other committee you serve on, Pete? Because I don't remember.
Board member, yeah. Sure.
Okay. Well, I forgot what other committee he's on. And I think everyone introduced themselves. We also have, and Joe, he's not here right now. All right, so tonight, I'm looking forward to hearing from you, Brian. And you already wrote your title there, which is great, Senior Advisor to the Mayor Adams on, I can't read the rest, on the-
on severe mental illness.
Yeah, I was gonna say, does it say SMI there? Okay.
Yeah, I'm not sure what you're looking at, where I might, what it might be something I just have on default on Zoom, so I'm not sure.
Yeah.
But yeah, that's my title.
Yes. So I'm looking forward to hearing what you have to share this evening. And if you could give a little bit about who you are and then go into your presentation. I don't believe you have any PowerPoint slides because
I do actually. I was hoping
you
to share
do?
my screen and show a few, if that's all right.
Okay. Nellie?
If that's a problem, I can probably wing it without them.
No, it's better. I think it's better for me personally. So if Nellie will allow you access to do that.
Yes, he has access. You can share your screen.
Okay, let me try and start that now. No, just go
Thank you,
into-
Nellie.
Yeah, just go into slideshow mode. And here we go. Okay, you're seeing my slides, right? Great. So hi, everybody. Great to be with you tonight. Really appreciate the opportunity. My name is Brian Stetton, as mentioned, and I'm a senior advisor on severe mental illness at City Hall. I'm an attorney and have been working, I'd say, really full time for the last 15 or so years. It's been my life's work to try and make sure that the mental health system is responsive to the needs of people with severe mental illness who are trapped in the revolving door, often because they lack insight into their illness and have difficulty accessing services on a voluntary basis. And of course, that's combined with the fact that our systems are shamefully under-resourced. And I had actually started, I'm from New York. I started in this issue area here as an assistant attorney general, going back about 25 years now. I was involved in the drafting of Kendra's Law when I was a young assistant attorney general. And I spent about 10 more years in state government after that, bounced around a little bit, and it was nothing that ever meant as much to me as the work I had done in making Kendra's Law happen. And we'll talk a little bit about Kendra's Law tonight. But about 14 years ago now, I became the policy director for an organization called the Treatment Advocacy Center. I moved down to DC and I spent about 13 years there as a national advocate working to change state laws around the country, and did not expect to be coming back to New York, but circumstances arose that allowed me to come back to my hometown and try and bring this agenda that I've been working on nationally once and for all to New York in a really meaningful way. And this legislation that we've proposed in the Adams administration, which I'm going to talk about tonight, is very much of a piece of this work that I've been doing for a long time, and very important to me. And I think to anyone who knows someone who has struggled with severe mental illness and had great difficulty accessing services as a result of lack of insight. I should say that this legislative agenda that we're now hoping is going to receive some attention now in Albany, now that they finally have budget done, springs very much from a plan that the mayor announced back in November, where we talked about creating a culture of engagement for people with severe mental illness. I think there was an unfortunate amount of controversy and misunderstanding about what exactly we put forth at that time. And I'll just, by way of background, before I get into what we're calling for legislatively, just give you some idea of this kind of larger picture and how it's going. What we said back in November was that we have to end this practice of walking away from people who we encounter in severe psychiatric crisis, often because of our misunderstanding. The city personnel who we have out in the field, for understandable reasons, have had for a long time a very limited notion of what the law actually allows them to do in the situations where they actually have opportunities to help. And so the mayor on November 29th issued a directive to our police department, to our mobile crisis outreach teams, to our EMS personnel, and to our staff at Health and Hospitals Corporation, who staff our city hospitals, to make it clear that, in fact, the authority to recognize that somebody is in a mental health crisis and who cannot recognize their own need for treatment, and who is refusing all attempts and all efforts that we make to persuade them to come to accept treatment on a voluntary basis, that in fact the authority to take action is broader than many have understood. And I'll get into the specifics of that a little more momentarily. But in putting out that directive, we did not in any way change the law or change city policy, right? I mean, it's not like there was some previous policy that was based on the misunderstanding of the law. The reality is that there was an absence of direction. We filled in a gap because that gap had previously been filled in by this pervasive misunderstanding of a more limited authority. And as I say, I'll speak more specifically about what I'm referring to momentarily, but let me also just say that along with this announcement that we were going to be taking this direction, we also made clear that we were going to be training our police officers and mobile crisis clinicians, the frontline folks who we have actually interacting with folks who are in crisis on the streets and in the subways. And we wanted to make sure that they had this more complete understanding of their legal authority. And so we have enhanced the training materials and included a section on what it means to be unable to meet your basic needs as a form of being dangerous to oneself. We also, I think it's important to note, have been trying to take the burden off of the police department. I think there was a really unfortunate misunderstanding that this plan was about really kind of pushing police forward and kind of making these decisions. The reality is that there are two laws in New York that we rely mainly upon in recognizing people who are in crisis in the community and bringing them to a hospital for an evaluation. And that person making that determination is not actually having somebody admitted to a hospital. They're simply making a decision that someone should come to a hospital to be evaluated by a physician, where that decision will be made more definitively as to whether to admit them to a hospital. But this is authority that is granted to police officers under Section 941 of the mental hygiene law, and also to certain types of clinicians who receive mobile crisis training and are certified by our Department of Health and Mental Hygiene, also have this authority to do this engagement and try to persuade people to accept services voluntarily, and as a last resort, use their authority to transport a person against their will. And we want to have clinicians as involved in this as possible. We are actually trying to do as many 958s, that is clinician directed removals, rather than 941s as we possibly can. And so we did a couple of things to really kind of start the ball rolling and kind of moving further in that direction, to kind of tip the scales towards clinicians, recognizing that we are never going to have as many clinicians on the ground as we do police officers. It's impossible to get to the point where these decisions are mainly being driven by clinicians, but we want to bring as much clinical input into this as possible. And so we have started to create interagency engagement teams where we are pairing police officers with clinicians, recognizing that police have an inescapable role in this process, because if we get to the point where we do have to put somebody into an ambulance, bring EMS to the scene, and transport someone to a hospital involuntarily, and it's not something the person wants to do, you can't ask a nurse or a psychologist or other clinician to actually effectuate that kind of removal. At that point, you are going to need a police officer. You want it to be one who has a specialized training in this particular task, who is going to use the minimum of physical force that it takes to actually accomplish that job. But you know, there is this necessary role for police in that part of the process. That said, it is, of course, always better to have a clinician doing the actual engagement with the person, right? For a couple of reasons. First of all, it's obviously less triggering and less disturbing and scary for a person to engage with someone who is not wearing a uniform with a gun on their holster. And also, obviously, a clinician has more specialized skill in actually determining that somebody meets the legal criteria to where there is some basis to act. So we think that this model of pairing the two, where you have a police officer who has some specialty in doing this work, acting in conjunction with a clinician who will take the lead in that engagement, is the optimal way to approach the need to do this work. And so we have these 6 new teams that we have deployed in Grand Central and Penn Station, and we have plans to actually expand this model, bring it above ground as well, and to do a lot more of this. The other thing that we have announced last year, and we now have in practice, is a clinical support line for police officers, because, you know, as I said, we recognize there are always going to be situations where police officers are going to have to make these decisions independently. Just in the course of their ordinary patrols, police officers sometimes encounter people who appear to be in psychiatric crisis, and either there's just no opportunity to get a clinician to the scene, such that the police officer has to make that call. But we want to bring clinical input to bear in that decision making. And so we have this new support line that just recently went live, where police officers are able to call in and speak to a clinician. This is staffed by clinicians from our H&H system, who will give that officer advice as to what can be done about the situation that they're describing. And the officer can share visual information, turn the phone around and get the clinician's opinion as to whether there is grounds under the law to bring the person to a hospital for evaluation. But I think even more importantly, explore other avenues that might be pursued before we reach that unfortunate point, right? Maybe this is somebody who would be willing to accept transport to one of our support and connection centers where people can get respite on a voluntary basis. And it's a lot less daunting than going to a hospital. Maybe this person refusing transport to a hospital would be willing to accept that kind of transport, and it didn't occur to the officer to ask. Maybe this is somebody whose whereabouts are reasonably predictable and we could come back to them in a day or two. We can send a mobile crisis outreach team out there and take some time to establish some rapport and over time get to a point where we can get that person to accept the voluntary transport. These are all opportunities that we're going to explore with officers before we get to the point where we say we think it's appropriate to do an involuntary removal here. So, this is the plan we have been implementing over the last couple of months. I'll just speak very quickly about the things we're not doing that I think many people had the impression of. One is that there's nothing about this that is designed to increase the numbers in meaningful ways of people who we're bringing in off the streets and trying to fill up our emergency rooms, which are, of course, are pretty overburdened right now. This is really focused on a fairly small but highly visible population of folks who are in acute psychiatric crisis in our streets, unsheltered. And there's nothing in here that calls for sweeps of people with mental illness generally in a way that I think has stirred up a lot of really unfortunate fear. As I also said, this is not about expanding the powers of police. This is about interpreting the law as it really has long existed, but hasn't really been understood. And I should also say this is not what we have put forth as the answer to fixing our dysfunctional, long neglected public mental health system. Right, and more recently, in February, I believe, Commissioner Vassan of our Health and Mental Hygiene Department revealed our kind of blueprint for how we're going to fix the mental health system with all kinds of new investments and things like clubhouses and IMT and ACT teams and to address mobile crisis, all the resource needs that we are very aware of. And of course, we're working with our partners at the state to get more hospital beds into the city. And there's some really good things in the new state budget that I think are going to help make that happen. Nothing in this plan suggests that we think that we're going to solve this problem simply by bringing people off the street into hospitals if we don't have that continuum of care to meet their needs and get them to back to living their best lives as we all want. But what we're trying to recognize with this plan is that when you encounter somebody who is in acute psychiatric crisis, really our only choices are to bring that person in for the medical care they desperately need and try and get them the help that they require using the resources we currently have available and doing the best we can by them, or alternatively walking away from them, right? And if we're walking away and saying that we can't help them, we should at least be honest enough and say it's because we don't, the cupboard is bare and there's nothing that we have for you, rather than kind of hiding behind this false excuse that the law doesn't allow us to help them. So that's really what kind of drove and motivated the policy. And I should say this is actually going quite well in the months that we have had this in place. We have a number of individuals whose stories are still being written. I mean, we haven't gotten to the point where we've gotten them back into the community because these are generally folks who are going to require a few months of hospital care. But, I'm happy to say that we have a number of individuals who are currently receiving the extended hospital care that they need. We have some partnership from the state to make that happen, where they've opened up some new units to facilitate that. And, we are working very hard with them and to get them back to the community into a supportive housing situation. So, there will be more to say about that in the months to come as the plan kind of matures, but I'm very encouraged by how it's going. But I do want to talk to you about the last piece of this announcement that was made in November, which is this legislative agenda that we are now hoping that we can create this kind of groundswell of support behind. And this kind of brings me to this point I've alluded to, which is how we think the law has been misunderstood in New York. And, that we have a standard like every state that says that a person is eligible for care, even though they don't recognize their own need for it, and can be brought in from the street to a hospital for a medical evaluation. And ultimately, if the doctor makes these determinations, definitively admitted to that hospital and retained for care. If we find that the person is exhibiting symptoms of mental illness, not just has a mental illness, but is actively symptomatic, and at the same time that those symptoms, that behavior creates a likelihood of serious harm to that person or others. And that basically comes down to a finding that the person is a danger to themselves or others. And when we have encountered individuals like this very sad figure that you see in this slide, we have sometimes interpreted that notion of danger to self or others very narrowly. That is, we have had the idea that a person is only a danger to themselves. Look, the danger to others part is fairly straightforward. It tends to involve a person who's kind of acting out violently or some way that puts people in reasonable fear. But when we say that a person is a danger to themselves, there has been a kind of a pervasive myth that requires a finding that the person is suicidal, or that they are acting out in some outrageously dangerous way that puts them at risk of imminent harm. They're running into traffic, or they're trying to jump off a roof because they think they can fly, or maybe they have some medical condition that is creating some imminent risk where it's just a medical emergency. If it's not addressed immediately, they could die. Those situations have generally been understood as examples of danger to self, and they all absolutely are cases of danger to self. But there is another swath, right? Another broad category of danger to self that has been completely missed. And that is the situation where a person's mental illness is preventing them from meeting their basic human needs: food, clothing, shelter, medical care, such that they may not be at imminent risk of serious harm, but they are inevitably at risk of serious. We know that over time, serious harm will accrue to them because they are living in a way that is simply not sustainable. And again, if we don't see this in combination with mental illness symptoms, it doesn't meet the standard, and there's not anything we can do for that person in a hospital. And there's lots of people who you encounter. The majority of people who you might see that are unsheltered are not necessarily exhibiting obvious symptoms of mental illness. But for those who are, there is very clear case law in New York that tells us that is a form of being danger to self and actually does give us authority to act. And so the case that is sort of the landmark on this, for those of you who have been around since the 80s will remember Billy Boggs, a homeless woman on the Upper East Side, and it became kind of a famous case where the Koch administration was trying to get help for her, and there was resistance from the New York Civil Liberties Union, which argued that of the many disturbing behaviors that she was engaging in on the Upper East Side, such as tearing up money that was handed to her and kind of screaming at passersby and urinating and defecating on herself, that none of those in the NYCLU's view rose to the level of danger because they were interpreting the law narrowly. And the court rejected that narrow interpretation. It said quite definitively that a person may be involuntarily confined for care and treatment where his or her mental illness manifests itself in neglect or refusal to care for themselves to such an extent that there is presented serious harm to their own well-being. And, in the decades since this Boggs decision, there have been a number of court cases that have involved individuals along the lines of Billy Boggs, and the courts have made similar findings. And yet somehow this message has not fully permeated to the street level where it's universally understood by our police officers and our mobile crisis clinicians who have often had this very narrow view of what it means to be a danger to self. And so this kind of brings me to this legislative agenda. So as I say, we have gone ahead and publicized and train and begun training of our personnel to make them aware that it is already the law in New York that if you cannot meet your basic needs, you are potentially a danger to yourself. And that is the law of the state, even though it's not explicitly in the statute. New York is one of only 4 states that don't actually say that explicitly in their law. We have a vague statute, but because it's been said by the court, it is the law of the state. Courts make law as much as legislatures do. But we feel very strongly that it is important that the statute itself say this as well, because it will be enormously helpful in getting this message out to all the professions that are engaged in interpreting this standard throughout the process. So it's not just the personnel who we have engaging with people on the street, right? It's also doctors in hospitals. It's also lawyers and judges in courts when people challenge their civil commitment and there is a determination that needs to be made about whether the person continues to be dangerous to themselves or others. And so we have this 11-point legislative agenda, and I've been talking a lot about point 1 because I think it's so important. But what this agenda is really just designed to do is address not just this, but the various things that we feel stand in the way of us getting help to this population who we encounter in psychiatric crisis, just flaws and gaps throughout the section of the mental hygiene law that addresses these situations, that if we could fix, it would greatly aid our ability as a city to make sure these folks get the help that they need. And again, I'm not suggesting that this is all we need to do to fix our mental health system. This is a complement to the many things we're trying to do, the investments that we're making to kind of bolster the continuum of care for people with severe mental illness. But this agenda is premised on our belief that there are folks who, no matter how great a system we build, are not going to come to it on a voluntary basis by no fault of their own, simply because this is a very cruel illness that often robs people of insight. It robs them often of an understanding of what their needs are. And so there is always going to be a need for an involuntary component to a public mental health system. And it's not that we want to lead into that. We want to have people self-directing to the greatest extent possible. But for many individuals, at least for a period of time, if we're not willing to make this care available to them involuntarily, it's not going to happen for them at all. And I just think that that's a reality that we have to recognize, and that's really what this particular agenda focuses on. It's a narrow focus. Again, it's not everything we need to do. But I will also say, before I kind of get into the 11 points, that for this to happen, it's going to require a groundswell of grassroots support. This is going to have to be something that lots of community-based constituencies are demanding. And that's why I'm with you guys tonight. I'm hoping to meet with lots more community boards around the city. But I think, neighborhood and civic associations, BIDs, organizations, community-based organizations that work with the mentally ill and provide services to them, the unions of folks who provide care in our hospitals, and all these organizations, I think, are going to have to come together. I'm hopeful that we're going to get support from NAMI and other organizations that represent people with mental illness and their families. I'm not blind to the fact that there is going to be some opposition to this, because it's always controversial when you're talking about expanding the availability of involuntary care. But I know that there are many, many folks in our city and state who care deeply about the needs of the severely mentally ill and realize that we have to make this available to people by all conceivable means if we're going to get people help. And so, that's really what I'm hoping that we're going to be able to spark in the next couple of weeks. And, to be blunt about it, there probably isn't enough time in the current session to enact this. But I do think that we have to kind of start the process, use the time we have left in the session to bring attention to this, and hopefully create some momentum that we can ride into next year. So let me just kind of walk through what we're doing in this bill, which we call the Supportive Interventions Act. And as I've already talked a lot about, the first point here is that we want to actually make explicit that a person's inability to meet their basic needs for food, clothing, shelter, or medical care, when combined with symptoms of severe mental illness, is a basis to say that this person is potentially a danger to themselves. a corollary of that, I think is just as important to make explicit in the law, and I think is really also just as much a matter of common sense. It's very frustrating often to our mobile crisis teams when they do bring somebody into a hospital and they do manage to even get them admitted. And sometimes they'll stay at the hospital and sit with the person and talk to the admitting physician in order to help them understand what was observed in the community to make that evaluation go right and get that person admitted. It is not uncommon for that person then to be streeted. Sometimes hours or later or the next day, another doctor will come on shift. The person will have received medication in the hospital. They'll have stabilized to some extent. Their behavior is no longer as disturbing. And the doctor looks at the person and says, "Hey, you seem to be doing okay now. We'll let you go." And this opportunity to get the person the care that they needed has been squandered because it's going to take some time to help somebody achieve recovery. It's not something that could be done in a day or even a week, and to be realistic about it. And so what we want to say explicitly in the law is that an evaluation of whether a person is a danger to themselves or others has to take account of more than just how they appear at the moment of evaluation. It must also take account of whatever information is available to the evaluator about the person's recent behavior, their treatment history, their ability to adhere to outpatient treatment, and the risk that they're going to suffer harm over time, not just the potential harm risk of imminent harm, but also the potential for them to suffer harm that will accrue over a period of time. Should also be considered when determining whether someone is currently dangerous to themselves or others. Other things that we seek to address in this legislation, we have very severe staffing challenges in the city, and one of the greatest barriers we have to meeting all the resource needs that we have out there is just finding the professional folks to work with this population. And there are certain things in the law that really exacerbate these challenges. One of them is the requirement that the evaluation that a person meets these criteria to be admitted to a hospital and to be retained in a hospital, that evaluation be performed by a physician. The reality is there are other clinical professionals who are just as qualified for that particular task. It's not a task that involves someone making a medical decision. To diagnose somebody with a mental illness and to say that they are potentially a danger to themselves or others is a decision that could be made just as well by a psychologist, a psychiatric nurse practitioner, a licensed clinical social worker. These are all professions that have the authority, for example, to diagnose mental illness and bill Medicaid for those diagnoses, but our law does not allow them to perform that diagnosis in the context of admitting someone for care in a hospital. So, as many states already have, we need to open up this authority to perform clinical evaluations to these other professions. That will ease the burden of hospitals greatly. It will allow the doctors that we have on staff in these psychiatric wards to focus much more on patient care. Similarly, we have great need to create more of these mobile crisis outreach teams I've talked a little about already. There are only certain clinical professions right now that have the authority under the current law to receive certification to serve on these teams. There are other clinical professions that could be doing this work: licensed mental health counselors, licensed marriage and family therapists, all as part of their training have enough knowledge of mental illness to perform this kind of provisional determination that happens in the community. Again, this is not a decision to admit someone to a hospital. It's just the decision to have somebody brought to a hospital for evaluation. And by opening the authority to serve on these teams up to these additional professions, we will be able to create many more of these teams and serve a much larger share of the population in need. Other things that we seek to do through this legislation, we're calling the Supportive Interventions Act. We want to authorize shelters to have the authority to direct the transport of residents, to hospitals for evaluation. It's obviously very common for people who are in our shelter system who have severe psychiatric needs. Sometimes they engage in behaviors in the shelter that makes it apparent to the staff, the mental health staff of those shelters, that this is a person who needs to be at least to be evaluated for potential hospital admission. But unlike those mobile crisis clinicians, mental health staff working in shelters don't have the authority themselves to direct that transport. And so what they have to do is call police to the scene and rely on a police officer's determination. By the time the police officer gets there, the person's behavior may have changed in a way that the police officer is not observing what that mental health professional did. And you have the rather absurd situation of a police officer kind of overruling a mental health professional and saying, I don't think this person meets the criteria, and the person is kind of left in the shelter. We should be able to give the staff of these shelters, who are themselves mental health professionals, not talking about staff generally, the authority to direct these kinds of removals and to bring police to the scene to simply effectuate, along with EMS, the removal to a hospital. Similarly, our mobile crisis teams and other community-based providers often are not informed when clients, people that they are serving, wind up in hospitals because of whatever behaviors they're engaged in when they are on the street. We have nothing in our law that requires a hospital to inform a community-based provider that they have admitted one of their clients or they have discharged one of their clients. And so community-based providers are often completely in the dark as to what has happened to their client. They have to do detective work, call around to area hospitals to figure out where they went. We have language in this legislation that would require any admission decision or discharge decision. When you look in the database that we have, that makes it very easy to see that somebody is on the patient roll of a community-based provider. Simply inform them of the fact that you've admitted or discharged their client. And additionally, when you are going to discharge someone, when you're planning discharge, we want language in the law that requires that if that person is currently on the census of a community-based provider, you not only inform them they're coming out, but work with them to plan that discharge so that you can make kind of a warm handoff and not wind up sending them to some other community provider and having them starting from scratch. The remaining pieces of this legislation address the law that kind of started me on this journey all these years ago, which is Kendra's law, which is our law for outpatient commitment. When a person does not currently meet criteria to be hospitalized, but has this history of being stuck in the revolving door, such that we think it's very likely, if they're kind of left without supervision and monitoring and supports, that they are likely to disengage from the treatment that's been prescribed to them and wind up back in the hospital again and again. We have the opportunity under Kendra's law to release that person from a hospital with a court order attached to their treatment plan that creates a mutual commitment where the person is not only expected to adhere to their treatment, and it's not going to result in punishment if they don't. It's simply going to result in action that gets them back into the hospital under evaluation if that need arises. But also puts our system under court order as well to actually provide the services. And this is something that has become a real fixture of New York State's public mental health system, has been remarkably effective in improving outcomes for people who are stuck in the revolving door and helping them stay out of the hospital and stay out of jail. Really, we have nothing like it in terms of its effectiveness. But a great frustration we have with Kendra's law, AOT, assisted outpatient treatment as it's known, is that our hospitals are often unable to get people into these programs because they're not making the referrals to our city AOT program. We're very reliant on those hospitals making referrals, and some have kind of bought in and do that routinely, and others discharge patients who meet the criteria for AOT. That is, they have this history of being stuck in the revolving door such that they are eligible for it under the law, but hospitals discharge them anyway without us even knowing about that. And we miss these opportunities to help people do better and stay in the community, stay out of jail, stay out of the criminal justice system. So what we want to do in this legislation is simply make it a part of the standard of care for a psychiatric inpatient. Hospitals must evaluate whether each patient meets the criteria for Kendra's law prior to discharging them. If they don't, that's fine. But if they do, make the referral and keep records to make it clear that this has been done in every case. We also want to make it easier for treatment records to be shared with our investigators for our AOT program, because the law requires that we have to show the court that the person has a history of disengaging from treatment. There was a very unfortunate court decision that doesn't allow us to access that person's treatment history unless they give their consent. And people in hospitals often do give their consent to this because they're kind of viewing the opportunity to participate in AOT as a way to get out of the hospital a little bit sooner. But where we often run into a roadblock with this is from people coming out of Rikers, right? People coming out of our jail system who really desperately need Kendra's law as a way of staying out of jail again, but don't necessarily recognize that themselves due to a lack of insight that is often just a part of this illness. And so they are, because they are often released from Rikers before we even have the opportunity to ask them if they're interested in participating in Kendra's law, often refuse the consent that our investigators need. And so what we want to do is put language in the law that will give the person an opportunity in court to challenge the disclosure of their records. But once that opportunity is exhausted, allow our investigators to access the person's treatment history such that we can determine whether they meet the criteria for Kendra's law and would benefit from it. So I know I've gone on a while, and I'm going to leave the remaining time for questions and not get into the more arcane pieces of the legislation. But I hope I've given you a flavor of what we're hoping to accomplish with this. And as I said, it's something I'm very hopeful that we can get your community board and many others across the city to demand of our legislators. So thanks for hearing me out.
Thank you, Brian. Just really quick question. I don't want to ask all of my questions at the moment. I want to give the
Wait, sorry, Maria, your microphone is on the top of your head and it's making
Thank
it
you, Roberta. Yeah, I tend to do that a lot. So just quick question. I want to give the other members time to ask questions, but specifically, I heard you mention 6 new teams.
Yep.
Of IMT, AO, which team?
So those aren't IMT or ACT teams, to be clear. Those are interagency engagement teams that are simply involved in patrolling areas that are known to have high concentrations of people who might be in psychiatric crisis, such as Penn Station and Grand Central. And their role is simply to see how people are doing and engage with them enough to determine whether this is someone who potentially needs to receive medical evaluation in a hospital.
Are they the clinician? They're clinicians.
So there are clinicians on these teams who are kind of leading that engagement, but this is something separate and apart from the much more in-depth work that our ACT teams and IMT teams do, where these folks actually become clients of theirs and they have kind of long-standing, ongoing relationships with them, providing them treatment. The role of these particular teams is not to provide treatment. It is simply to determine whether folks are in need of evaluation in a hospital. And so we have a clinician kind of leading that engagement, that interaction with the person, and a police officer on the scene to help effectuate the removal, calling EMS to the scene, getting that person to the hospital if it comes to that. And of course, they're doing everything they can to make sure that to make it possible that that person will go voluntarily if that can happen. And
which boroughs are these teams working in?
So right now we have them in Manhattan. We have them in Grand Central and Penn Station. And it is a concept that we're hoping to spread more around the city.
And specifically, it sounds almost similar to an IMT team.
It's really
but
not.
It's not.
Yeah, it's really nothing like IMT, right? So IMT teams have clients and they have long-term relationships with folks.
Yeah.
Right. And they're kind of, there was an article about IMT in the Times yesterday where you see like how they kind of work with people over time to help address the full range of their needs and make sure they're getting the benefits they have coming to them, and work with them to get them into housing and make sure they're taking their meds, and I give them their meds if necessary. That's a whole nother level of engagement and interaction that's not at all the role of these particular teams I'm talking about.
Okay, I have some other questions, but I'm going to let the committee members go first. If they don't come up, then I'll ask JD.
Thank you, Maria, and thank you, Brian, if I can call you Brian for this.
Please do, sure.
Incredibly difficult situation. I have 2 quick clarification questions.
Sure.
You kept using the term clinician.
Yes.
Clinician. Is that a whole range of possibly trained people?
It is. So that would include psychologists. It would include psychiatric nurse practitioners.
Okay, I got you. And the second question, very quickly, if a person has ulcerated feet and they're on the street and they're in danger, I've always understood as a layman that they can refuse treatment. This is true would that change or not?
Yeah, so to be clear, if somebody is not exhibiting symptoms of mental illness and has a medical condition that, you or a doctor might say really requires medical attention, and they don't have any interest in receiving medical attention for that, that's their right to make that determination for themselves. It is when we have the combination of severe mental illness symptoms and some medical condition that does create a likelihood of serious harm for the person, where we can say that, the mental illness appears to be interfering with the person's ability to make that decision. And so that is where we have some authority under the law to intervene and bring that person to a hospital.
Very complicated. Thank you, Brian.
Sure thing.
Oh, Travis?
Thank you, Maria. Thank you, Brian, for your time. I actually had 3 questions for you. I'm going to fire them off really quickly. So number 1, I work in human services, and there's a huge recruitment issue happening here.
Sure.
So I want to understand where the money is coming from, or where's the budget in place or allocation for that, for the recruitment of staff to be able to fill these teams. And is there a recruitment strategy in place from the mayor's office around this? Number 1. Mm-hmm. Number 2, you mentioned training of the police. For those instances where the police come across someone and there's not a team available, like it's in the middle of their work.
Yeah.
Can you give us a flavor of what that training will look like for them to engage that person or to contain the issue until they get the team there? And then number 3, what is the plan as far as the public awareness goal or strategy, or creating a culture around calling these teams for our citizens across New York, so we don't have a case like Jordan Neely recently, where we had a quote unquote good Samaritan acting on their own accord. Yeah. So those are the things I want you to touch upon.
Yeah. So those are great questions and tough questions. Let me start with the middle one about police training. So there are kind of 2 levels to this, right? There's the crisis intervention training, which is a full week training course that we have, the NYPD has committed to delivering to its entire force, and is in the process of that. I think we're at the point now where they've trained, I think they're at about half. They got a ways to go to get to where every officer has received that week-long training, but it's something the department is committed to. It's a huge challenge because it requires taking people off the street for the amount of time to receive it. But that's ongoing, and that really is delving deep into the kinds of techniques you're talking about, right? There's the basic art of de-escalation, about making a person understand that they're not in trouble, and understanding the behaviors that you're going to encounter with someone who's having a mental illness episode that don't necessarily create the danger that an untrained officer might believe it does. So, that's incredibly important training, and, it's a work in progress getting the entire department there, but it's something that NYPD has made a commitment to. The particular training piece that I was really talking about in my presentation is really apart from that, and it's simply about being aware of the standard for involuntary removal, and to understand that, the concept of danger to self or others is broader than the kind of pervasive myth that had filled the vacuum prior to now, had led a lot of people to believe. So, it's much more limited in focus, and it's a kind of a quick hit training that we have given at this point to 90% of the patrol officers. It's been delivered in a video that was seen that they view at roll call, a PowerPoint presentation they view at roll call, and then they do a video afterwards to answer questions and make sure that they've actually absorbed the information. But it's not to discount the importance of the kind of more in-depth training that you've talked about. As far as how we're going to make sure that we can create the workforce that it's going to take to make this happen. It's something that we absolutely have in the mayor's budget, and more details will be revealed in that when it's presented to the city council in a couple of weeks. But we have committed to creating 800 new slots for IMT and ACT, which I think gets us a very long way to meeting the shortfall we have now in terms of the demand exceeding the supply. So there is money. There are millions of dollars that have been allocated to pay those salaries. I think we're all kind of frustrated by the fact that these jobs don't pay as well as maybe if they did, we would attract lots more people into those professions, and that's a tall order. It's something we need a lot of help from the state to make happen. I know that the governor has a significant cost of living increase for mental health professionals in her new budget that I think is going to help. But yeah, I mean, I can't deny that what you're putting your finger on is an ongoing need, and it's something that we're going to have to really work on a lot. And there's also things we're doing with loan forgiveness that I think is going to be very helpful, both as a state and as a city, where for mental health professionals who are willing to work in our public mental health system, we are going to be forgiving student loans. I think there's things we have in the pipeline to create a pathway for people coming out of CUNY to have education costs covered in exchange for working in our system. So there's some things in the works, and I think more specifics will come out with our budget announcement to the council in a couple of weeks. Your last point is probably the toughest one of all. I mean, I agree with you. There is a need to ideally get mental health professionals on the scene at places where psychiatric crises are taking place. We have a program called Be Heard, which we have piloted in a couple of areas in the Bronx and in Upper Manhattan, where we are sending clinicians and not police officers to the scenes of mental health crises that don't really require police presence based on a certain number of factors. We have plans to take that program citywide so that when people call 911 and report an incident, the 911 operator will be trained to identify certain factors that may not necessarily require a police officer, and we can divert those calls to the Be Heard team, which will send clinicians rather than police. And so that's going to be expanded over the next couple of years, and I think that's going to go a long way to making some of these encounters go better. But the reality is there are many situations that do require police presence because of the nature of how the person is behaving. And so, to me, the ideal thing is to have a clinician on the scene, even in those situations, to pair clinicians with police officers, as we've talked about. So, I'm hopeful that through kind of proof of concept through what we're doing in the subways, we're going to be able to expand that particular approach and get to the point where every mental health crisis, whether it has to involve police or not, at least does involve some mental health professional.
Thank you. That was a thorough answer. I appreciate it.
Sure thing. Thanks for the questions.
Maria, we can't hear you, but is it okay if I start?
Katie, you're up next. I'm sorry.
I'm sorry. Sorry. I was speaking. I said, Brian, that's why when I tried to cut you off earlier, it didn't work. Okay, Brian, I was saying that we have 5 people raising their hand plus 1 attendee. But before we go to the next person, Katie, I actually saw Hector next. Okay. Yeah, and I wanted to just ask a follow-up question. You said 800 new slots for IMT and ACT. I think you meant to fill slots for staff.
No, those are going to be new. That many more individuals will be able to be served by those programs.
Those are treatment. Those are
new slots, meaning treatment slots. Thank you.
Exactly. Yep.
I just wanted to clarify that. Hector, and then Katie.
Great. Brian, thank you for a really informative presentation. I do have a question. I know you touched on it, and you also mentioned that the teams that are going to be implemented now are not really involved with the follow-up. I mean, your teams are basically to get them off the street, and I understand that and seek treatment for them. But are there any plans to do follow-up? Because honestly, I mean, some of these folks will obviously end up back in the street, or when you find them residents or treatment, so they end up fails because basically there is no follow-up to keep an eye on them and make sure they're taking their meds, doing the treatments, that sort of thing. Is there any plans for that?
Yeah, there absolutely are. And thank you so much for that question, because it's a really important point. Obviously, we're not accomplishing much if all we're doing is getting somebody to the door of the hospital, giving them some medication, stabilizing them, and then turning them back out to kind of repeat the cycle. So, this is something our health and hospital system, I think, is very committed to. And I'm really seeing good things happening in terms of making sure that, we're fulfilling our obligations to plan discharges, right? From the day a person gets into a hospital, the discharge planning is supposed to start. And that means figuring out where they go from there, right? So you want to have them in the hospital long enough to get the meds right, help them, kind of learn basic skills of self-care that may need to be kind of retaught after the kind of ravages of what the person has been through. But we have to start the process of getting that person into not just supportive housing, but the right kind of supportive housing that includes all the supports that meet that particular person's needs. And so, we have social workers on the staff of our H&H hospitals. We're connecting people with our community-based providers and who are coming in and working with them. And this is an obligation that we have for each individual that comes into the system, where we have to start the process of figuring out where this person is going from here when they are ready for discharge, making sure we're not discharging them prematurely. And, the unfortunate reality is that sometimes people have to go sometimes to temporary housing into the shelter system because we don't have all the supportive housing we need at this time. We're doing a lot of things to kind of build that supply of supporting housing up. We have various programs that are leading to more and more units. But, where we sometimes lose people is that we have individuals who don't want to go to the shelter system to wait for that housing slot to open. And so they go back to the street, which is obviously a tragedy every time it happens. So I think, one of the important things we're doing is making that shelter housing more attractive, right? Increasing the number of our safe haven shelters where people get their own room and more independence and aren't, in a congregate shelter that can be kind of scary and unsafe, and where there's a curfew that sometimes makes it kind of hard for people to kind of conform to lifestyle wise. So, I think there are a lot of good things happening on that front. It's going to take time. We have a system that's been neglected for decades. It's going to take time to address these needs. But I do think we're on the right track. And we, if you take a look at this kind of broader mental health blueprint that Dr. Vassan unveiled in February, and I'm happy to put a link to it in the chat. There's a lot that we have kind of set out for ourselves, benchmarks that we've set out for ourselves that we're going to meet over the next few years. And I think that's fair for people to judge us on whether we've accomplished it. But
Brian, can I stop you right there?
Yeah, sure.
Thank you. I'm going to let Katie go, and then Paul, I want to let you know we do not have a chat feature. So you can email to Jesse or Nellie the plan you were talking about. Also, if you could email the slides.
You got it.
Yeah. Thank you. Katie, and then Paul, and then Roberta.
Great. Thanks, Brian. And by the way, just thank you for mentioning the importance of safe havens and things. I'm actually on the board of BRC, and we're big fans of that. So had a couple questions for you. You mentioned earlier the importance of sort of public awareness and that public support is going to be needed. And it's interesting, we actually had this subcommittee helped sponsor a talk just last week, or a forum on mental illness. And one of the suggestions that was made by people out in the on the streets was how helpful it would be to have some sort of awareness campaign, like an ad campaign, to show that homeless people with mental illness are predominantly not violent, to get people sort of more sympathetic and more supportive, as opposed to just being so scared all the time, right?
Right. And
so I wondered, so one of my questions is, I just wondered what you think about that possibility, right? Of trying to sort of demystify some of what's out there and have that kind of ad campaign, and whether or not the mayor's office might be supportive of that. And I also, you had talked about this, desperate understaffing of these positions.
Yeah.
And one of the things that came up last week is that they said, it's not that we need more positions created, it's that many of the teams that we already have aren't staffed, right? And as you said, like, they're not paid well.
Right.
And they have these student loans and things. And so I know that there was just a suggestion made that at least mental health workers should have the same COLA that city workers are getting.
Yep.
And I wondered what your position would be on that. And then just very last, I wondered if you could address a little bit the sort of slippery slope argument. Like, yes, you don't want to say people can't come off the streets unless they're in imminent harm. But it seems like you could say, well, they're not taking care of themselves, like, it seems like you could go to either extreme. And how do we protect against that?
Yeah, well, all great questions. So let me start with the easy one, which is whether we'd be interested in participating in a public service campaign to get information out and help people understand mental illness better. Absolutely, we would. So, whatever that effort currently entails, if you want to bring me into it, get me involved, and I'll bring other people in city government into it, would very much love to be a part of that. Because as you say, it is so important. We don't want people to have needless fear of their mentally ill neighbors and loved ones. And, we have study after study that tells us that whatever association there may be between untreated severe mental illness and violence is completely mitigated by giving people treatment. And when people are in treatment, there is no association whatsoever. I do think we kind of ignore at our peril the reality that mental illness that is severe and untreated does sometimes lead to violence, right? I mean, that's something that, we often don't want to talk about because we're so understandably afraid of perpetuating stigma. But, I think to a great extent, a lot of the stigma we have is perpetuated by some of the horrible things people read in the newspaper about people who we failed by not making sure they got the treatment that they needed. I think that, but I think there are a lot of things, that we can do in conjunction with each other to really solve that larger problem. Remind me your next question.
Wait, hold on. So you don't, I guess you were just talking about the slippery slope issue. And I was wondering about the COLA equal to city workers.
Right. So the COLA is really a state function, setting the COLA every year. And I'm happy to say that the new executive budget, the new state budget does include, I think I don't want to say the number because
it's in the budget. It just passed on Tuesday.
That's right. It's in the budget, but there is a significant COLA increase for mental health professionals.
And they're for contracted workers, Katie, not just direct city workers.
Right. So some good news on that.
Okay.
Front.
For all not-for-profits in this?
Yeah. All not. In other words, those who have a contract with the city, and sometimes the state funds are provided through the city. Yes.
Right. I know. Yep.
It's amazing. It happened. Yeah.
It is. And thanks for the assist on that, Joe. Yep. As far as the slippery slope, there is due process built into this. I think it's important for people to understand. Ultimately, to retain someone in a hospital is going to require, to retain them for more than a few days is going to require us going to court. A person has a right to go to court almost immediately. They get an attorney from Mental Hygiene Legal Services. And there's an automatic court hearing that takes place if we're going to retain somebody at 30 days. And it has to be established by clear and convincing evidence that this person meets the legal criteria, and the legal criteria are significant. We're not talking about, retaining somebody for a trivial reason. There has to be a true demonstration that this person, mental illness presents a serious risk of harm to them or others. And, somebody who has a significant medical condition that may not present a risk imminently, but, over a period of time is going to lead to very serious health complications for them. That's meaningful. We're talking about people who, we encounter who sometimes have lice, who are not, going to the bathroom, who don't have shoes on their feet that can protect them physically from the elements. Who are significantly underdressed in cold weather to the point that they could be exposed to hypothermia. These are significant conditions, and it's really the kind of thing that it's going to take for us to convince a court that a person meets these criteria. So, I think it would be unfortunate to not get help to folks in this kind of condition, where it's really the mental illness that is preventing them from meeting their own needs. I mean, to me, it's just kind of the height of cruelty to say that we're going to just kind of leave you to the consequences of your supposed choices, when it's, to me, pretty clear that the person is not really making a choice, because their ability to assess what's actually happening to them is being clouded by this very cruel disease. So,
Let's put
I think,
Paul. No, I'm just trying to move us along because you're, by the way, you're really super thorough, which is so unusual. Folks coming to our committee to this degree, we really appreciate it.
Good thing.
Paul, followed by Roberta.
Sure, I'll try to keep it short. Brian, this is one of the most enjoyable presentations I've heard.
Thank you so much.
No, seriously, because when the mayor first announced the idea, the immediate pushback was, as we all read it, so, oh my God, they're going to sweep on the streets.
Right.
First of all, thank you for informing me. I'm ashamed to admit I did not know the legal background. I'm just glad to hear that what you're suggesting is legal, and there's court cases that have approved that, because the combination of something that is already legal and in its perfect state, in its best state, is actually much more caring than anything we've heard about. So refreshing. We're told that this is such a sprawling national problem. It's beyond our human comprehension. You've obviously put in years figuring out that, there's no getting around the fact it's awfully nuanced. It's got nuance that would make your hair fall out. But anyway, I won't take any more time getting the message out and informing the rest of our community boards and the population that there's a chance to start nibbling away at what remains a huge problem with a little bit of intelligence. And just the fact that it's legal and caring is really great news. I have no other questions. Thanks.
Appreciate that.
Roberta, followed by Betty.
Sure. So thank you so much for the presentation, echoing the things that Paul said. Very, very thorough, very appreciated. I did want to ask a couple of questions. The first two, I think, are pretty straightforward, which is just one, is there legislative language that if someone did want to, that they could look at? And then for the recommendations that the city is making, do these have any either professional association support or advocate support? Are there any further or external validators beyond the city asking for these items?
Yeah, thank you. So the answer to the first question is yes. And in the package of materials that I'm going to send over, I will include the bill itself and the memo in support, which accompanies it and summarizes its provisions. As far as validators, I mean, that's kind of why I'm here tonight, is that I'm in the process of trying to build up that stable. There are a couple of community-based providers who have expressed to me that they are strongly behind it. Project Renewal is one, BronxWorks is another. We are talking to NAMI, New York State, about it as well, and we'll see whether I have to talk to their board and see whether we can get them behind it. But it's kind of a work in progress, and just now with budget being completed, we're at a point where we can get people to focus on it. But I would say in the next couple of weeks, I hope to have legislative sponsors in both houses for the bill and an actual list we can put out of organizations that are behind it.
And Joe, if I could I appreciate that. Just another few quick questions.
No, go right ahead, Katie. I mean, Roberta, I can see it on your face. So I keep asking.
Appreciate it. So my other question, or one of them, is that are there sufficient facilities ultimately within the city to facilitate the implementation of these proposals?
Yeah. So, as I think I said earlier, we don't have any reason to believe that this is going to lead to a massive influx of people coming into hospitals. This is not like, the wall is going to come down and suddenly there are going to be thousands and thousands of people who suddenly meet the criteria. This is a plan that is focused on a very narrow subset of people with severe mental illness who have to meet, this very specific set of criteria. And it's generally focused on people who are unsheltered. When you look at the subset of folks who are unsheltered and severely mentally ill and exhibiting these kinds of symptoms and failing to meet their basic needs, it's a 3-digit number. It's not overwhelming. We are in the process of bringing, there's no question we need more psychiatric beds in New York City to meet the needs of not just this population, but a larger.
We have been
cohort of
advocating
folks.
that for a long time at this point.
Exactly. And we lost a lot of beds to COVID. We have a lot of things happening that I think are going to help us at least get back to those pre-COVID levels of psych beds in New York City. Part of the $1 billion investment that the governor announced that includes bringing another 150 long-term state beds to bear. We are in the New York City H&H system have committed to bringing back 200 beds that we lost in the last couple of years by the end of this year. And we're also working with Greater New York Hospital Association to bring back a large number of the beds that they have also lost, and having to repurpose them to treat COVID patients. So I think some good things are happening on that front. Yeah.
And then relatedly, does the city budget, is the city budget doing anything to further I know you've just mentioned H&H, so I imagine there is a city budget component, but the ongoing issues related to serious mental illness, I don't know if there's any kind of updates from where the city is at with that.
Yeah, so a lot of what we are going to put out is in the blueprint that Dr. Vassan put out, which again I'll get the link to you to see exactly what the investments are that we have in mind. Yeah, I mean, there's $50 million in new investments in mental health that are part of the budget that's going to be laid out to the city council in a couple of weeks.
Thank you, Betty. Betty, followed by Sabrina.
Yes, thank you so much for your presentation. It really, really is very good. When I first read in a local paper the initiative by the mayor, I said, oh no, this is going to violate people's civil rights and blah, 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 So you really shed light on it. And to follow up on that, I think it would be great if you guys could prepare some simple, whether it's comic book style or little stories of successful cases or hypothetical ones. This person had diabetes and they couldn't take care of the diabetes and blah, 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 blah. Something that illustrates why you would be doing this, okay? And the other thing is, once a person gets to the hospital, okay, so say they spend a night or two there, and then can they say, okay, I'm okay now, I'm leaving? So is it you have to go through some sort of legal procedure to keep them there?
Yeah, so those criteria that you be exhibiting mental illness symptoms and that you be a danger to yourself or others, those are the criteria to get you to the hospital. To actually admit you to the hospital, there has to be a finding definitively that you have a mental illness. You have to be diagnosed with it and also be currently considered a danger to yourself or others. And as long as that remains true, the hospital has the authority to retain the person subject to the oversight of a court, right? The person who wants to leave has the opportunity through the attorney that's assigned to them to challenge their retention in court. But if the hospital can make their case that the person actually still meets these criteria, they have the authority to hold on to the person. And there's no point at which there's an absolute right to be released. But except to the point where the person no longer meets those criteria, then they have a right to be released that very day.
So is the person forcibly kept in the hospital once it's determined that they have met the criteria? I mean, do they chain them to the bed, or
they don't chain them to the bed, but it's
not 1845 anymore, Betty.
I just wanted to get the flavor of it.
It's a locked facility that the person is in. So they have freedom of movement, but can't leave the facility.
Okay, and one last tiny question, which is a big question. I'm concerned once the person has gotten back in shape and everything, they have no home. What's your percentage of success of getting a person to some place of shelter?
Yeah, well, it's too early to judge the percentage of success behind this particular initiative that I've been talking about, because we're only a few months into it. But I can tell you that, we have a number of individuals. We have a weekly meeting with the various agencies that are involved in working with this population, where we come together and talk about a specific group of folks who have been really through the ringer and suffered greatly and have been very challenging, who have been refusing services. And we talk about why they're refusing services and what tools we can bring to bear to get them care. And through that technique and having health and hospitals there as part of the team meeting, we have been able to get a number of folks hospitalized for the long-term care that they require. And these are individuals who have not gotten this kind of extended hospital care at all in recent years. And it's a work in progress. We will see how we do, but we're working very hard with these individuals to get them back into the community, get them in supportive housing, and we're very committed to it. So if I come back to your meeting in a year, I think I will have something to say about how well we're doing. But it's to be written.
Yes, you can. Yes.
I think that is really a wonderful effort. Thank you.
Appreciate that. Thank you.
Sabrina?
Thank you for the presentation. I just thinking about, obviously New York City is a very unique city in many ways, with our unique problems that we have and the biggest subway system in the country, which allows to a lot of what's happening with this problem with folks who have severe mental illness. But I'm thinking about, like you said, this is your area of expertise, and then this initiative. Do you have any comparative cases or studies that have shown that this might work not only in the US but outside of the US? Because New York is different, right? But there are other cities around the world who have similar-ish problems that we might face, like big metropolis. Think about London, Paris, who have bigger subway systems. And I'm thinking about what have they done? Is that influencing this initiative, or it's just completely out of another scope and it just cannot be any comparable case with that?
Yeah. So, I can't speak so much to it internationally because, my work has been really focused on the approaches that the various states take and how the states try and conform their own laws to the constitutional limitations that have been handed down by the Supreme Court. I can say that, the idea of getting somebody hospital care on the basis of their inability to meet their basic needs is not particularly controversial or novel nationally. And New York is one of only 3 states that does not say in its law that is grounds for having somebody receive hospital care on an involuntary basis. And, as you say, New York is unique. So there is no other city, quite like New York in the states that have laws like that on the books. And it's also true that just because the laws are on the books doesn't necessarily mean they're fully implemented. So it's really hard to, point to a model because, I've had a lot of frustrations as a national advocate in just getting states to actually implement the laws and do the things that their laws allow them to. One of the things that was attractive to me about taking this job is that it's an opportunity to actually, work in a major city government where we can be implementers, where, if we get the tool, if we get the authority to do it, and we actually have it now, as I've said, through case law, we can go out and make it happen. And so I think that, we are breaking some ground in New York City. And, I think we're going to be a national model and we'll see where it leads.
Thank you.
Yeah.
So first off, echoing Paul and others, I'm extremely appreciative of this very thoughtful presentation, but also the thoughtful implementation of trying to solve the problem and not working to be perfect, because we don't have the ability to be perfect here. But you did bring up Civil Liberties Union and that case.
Yeah.
And I'm wondering what type of conversations or support is possible with not just civil liberties, but homeless advocates who have painted this as a sweep as removing people off the street so that we don't see them and we don't have to
Right.
deal with them. Because I think that's really key. We can only go so far to making a dent in the problem when we don't have the legal pushback from the civil liberties that continue to advocate to say, well, it's okay to let someone deteriorate on the street longer because they have the right to say no.
Right.
And again, it's a very, very difficult situation. I know there's no straight answer, but I think I'd like to understand if there is a conversation happening with the advocacy groups to have them understand where we can actually help people in the same way that they want to.
Yeah, a great question. Thank you. And so the answer is we're absolutely having that dialogue. In fact, just 2 nights ago, I did a forum hosted by Disability Rights New York, which is the state-funded protection and advocacy organization from New York State that has the authority to protect the rights of people with disabilities of all kinds, and even, you know, subpoena documents and bring litigation where they feel that rights have been violated. You know, I'm happy to say that they have not did not appear to be contemplating any kind of legal action against you know, the plan as we've implemented. There is litigation that has been ongoing for some years now concerning the city's involuntary removal policy generally, where you know, the plaintiffs behind that attempted to make this new policy part of that case and to try and get a preliminary injunction against us implementing this new plan, and that was denied by the court on the grounds that the plaintiffs in that longstanding suit did not have standing because they have not personally been impacted by this new policy. So, you know, I can't completely rule out the possibility that there's going to be some legal challenge from someone who has been personally impacted by it. But I am confident that we're going to withstand any kind of judicial scrutiny by it. If it comes to that, you know, we'll just have to hash it out in court and see what happens. But you know, I think what we're doing is perfectly within the confines of what the, you know, the appellate court said in that Billy Boggs case. We're not doing anything radical here, breaking any new ground. And so, you know, we'll just have to see how it plays out. But,
so Brian,
yeah.
I actually am hoping that there's an opportunity for where you can meet in the middle and that conversation's happening. So glad to hear that you don't think that there's at this point in time legal action. But what I really was hoping to hear was that both points of view are coming to the table, and hopefully that's something that your staff is actively doing.
Yeah, in terms of talking, absolutely we are. You know, I'm not terribly hopeful that we're going to find some meet in the middle sort of compromise approach. You know, to me, that would be unfortunate if we did, because I think this approach is important to go forward with as it is.
JD, give me one moment. I ask a few questions first. Okay, 1 second.
Sure,
so,
go ahead.
Yeah, so Brian, first, no matter what, we want to thank you for a seriously nuanced and thoughtful presentation. It is not sort of like a either or, black, white, nothing, you know, we know that this work is every shade of gray that exists, right? So a couple things I want to support you on. One is that folks who are seriously mentally ill and endangering themselves or others is truly a small subset of a subset. There's no question on that.
Yeah.
Unfortunately, they are the most visible and create the most impact on people around them. And that's why we have this ongoing issue of a sense of total, things are out of control when someone comes up to you or someone is on the street and it's in our face constantly. So this is a small subset, but I want to bring to you something else too. And I'm a provider of supportive housing, but it is important to note that DMH and DHS these days, in the last 5 years, are referring people who have more serious mental illness than is really suitable for independent supportive housing.
Yeah.
And I have seen this on a direct basis, and it's very disturbing to watch it because we have to match people up with the right kind of housing and the right kind of support services, right? You said this.
Agree.
So I have seen a couple of things where you need to, and our community board is also very engaged with the idea of not just supportive housing, but supervised housing, where actually people who need much more supervision on a regular basis than supportive housing can provide. We have a project in our district, a state-owned property that is a former YMCA and a former prison, Bayview, on West 20th and 11th Avenue. And our board has proposed a specific part of our affordable housing plan to, and we've endorsed a number of psychiatric beds at that location that would be supervised housing, not just supportive housing, because we believe there's a continuum of care here that needs to be different levels of people's needs. We've talked about that in this committee, in our land use committee in Chelsea, and truly endorsed it. We'll send you that information because this is something we're working on with the state.
Appreciate that.
Both OMH and HCR are involved in this, along with ESD. How's that for enough agencies? Sure, try to get something to happen. But what I also want to bring to your attention is folks who are seriously mentally ill, who will not succeed no matter what services they get in supportive housing.
Yep.
How can the work you're doing tie into to assist those providers to get those folks the right services? I have folks with AOT. I have folks, we've gotten guardians appointed. I mean, 100% every bit of care, but they will not comply whatsoever. Therefore, we find ourselves in housing court. Someone's being evicted. They have a permanent Supreme Court guardian, an Article 81 guardian in place, and they're not helped. They are literally just given, here's the shelters you go to. That to me is an absolute tragedy, because here's someone who was stable, decompensated, but couldn't make it because they would not self-medicate. What can we work with your office to help assist that? Because that is going to be many providers in our district. We have one on 48th Street where a person was totally lost it. There was a knifing. I mean, these are things that are serious.
Yeah.
With assaults involved, not just it's physical and not taking care of yourself at the same time. So what are your thoughts about that?
I appreciate you bringing that to my attention. I mean, one thing that I've thought about myself is the need to create like a forum to bring providers together with people in city government, where we actually talk about individuals, talk about cases, and kind of hone in on folks who, as you're describing, are not having their needs met, and kind of figure out together with everyone who has a role in the process at the table, to see whether we can find a better place to put that individual, and whether it's someone who needs to actually go back to a hospital for a period of time to maybe get meds right, or figure out what's going on with them. I just think you're talking about the kind of situations that we have to talk through person by person. So, right. I mean, let's think together, and let's follow up on this about, what kind of a group we might pull together, to have regular meetings where we have, specifically identified individuals that we can.
Because I'm going to give you a case in point. We worked with someone for 2 years.
Yeah.
They would not settle down. Everything, all kinds of providers, Article 81 guardian, go through the process, assaults back and forth. The man gets evicted. He is then part of a viral video 4 weeks later on the platform on 59th and in the train at people.
Yeah.
And the idea that that's what happened is not what our city should be about.
Yeah, especially as you say, the tragedy is compounded by the fact that the warning signs were seen. There were opportunities to get somebody help. Let's talk further about that, because I do think that the way to address
it's a minority, but it's that minority that is,
Yeah, but I think that, the same approach that is working well for us within, our kind of street homeless population, where we're bringing together all the groups that work with them, to coordinate response, I think could also work with housing providers.
JD, thank you very much. JD?
Yeah.
Yes, Brian, this is such a difficult issue. One question, perhaps I missed it. I think one concern some of us may have is with the training of these clinicians, the nurses, the psychiatrists, everybody, is there redundancy about a decision that is made about an individual? Is it just one person that makes that decision, or is it two?
So I think if we're talking specifically about the decision to remove somebody from a strict subway setting, bring them to a hospital, it just takes one. So
see, if there were, I would be a little concerned about that, because
Well,
That's-
keep in mind, yeah.
That's
so
that's just removal. That is not
Exactly.
evaluation and commitment.
You got to keep in mind, that's not a decision that's going to get somebody hospitalized. That's a decision that's simply going to get somebody transported to a hospital for evaluation, at which point a physician under the current law must determine that they definitively meet the criteria and then admit them. And then to have them held for a significant period of time to actually be admitted to a psychiatric ward, then it takes two physicians to make that, to corroborate that determination. So there's all kinds of due process built in.
Understandable, but
yeah.
it's that removal that I want to make sure that the people are adequately trained.
And the training is significant, right? The person has to have, first of all, they have to have a certain professional degree that involves, to get that involves certain training. But then on top of that, there is a specific training course about this particular decision-making that a person has to go through that's provided by the State Office of Mental Health.
Great. Thanks, Brian.
To get certification. Yeah.
Great. Thanks.
Dolores?
Sorry to come back. Just piggybacking on JD's question, racial training.
Yeah.
Bias training and anti-racism training.
Yeah.
I mean, it's very easy to make assumptions about someone's intent. If you're from Nebraska and you see a person is dark-skinned and you may assume they're a threat, right? It even happens to people from New York. You don't have to address it, but
yeah,
I think it needs to be very much part of that training. And if it isn't, it needs to be.
Yeah, and my understanding is that it is. I can't say definitively. I haven't been through the training course, but I would be very surprised. And you can follow up with me for a definitive answer. But my strong hunch is that that's part of the training that's delivered.
So
Joe.
Brian,
Yeah, Maria, go ahead. Maria? Or
Travis, you were going to say something and then I'll.
yeah, I was just going to ask Brian, can we ask that if it's not already involved in that training, that it be expressed to the mayor's office that the community boards demand that it's involved in that training?
So this is training that's developed by the State Office of Mental Health. It's not a city function to develop the materials that are provided in that training.
How do you feel about advocating for that?
But wait, we should just ask for the materials first before we advocate about something that might be there. So let's get the materials first.
Yeah, that's true.
Well,
That's a good idea.
Understood, Joe. However, what we're just trying to express, particularly because of what happened yesterday that we all saw today, that was obviously not a person trained in this. It doesn't matter. We saw someone be murdered, and race could have very much been a factor there. So I think what you're hearing from Travis and myself is that whether or not you're in charge of the training or not, whether the mayor's office or not, it is something that is being voiced as a concern that it is implemented if that one person is the deciding person on whether or not the person's removed.
Right. But again, they're only making a decision that the person's going to go to the hospital, and then, an evaluation by a physician is going to be much more determinative of what actually happens to the person.
That's true, but still being removed in a public space can be a concern that we need to be very careful about that. Also for sexual identity as well as racial considerations.
And I'm going to ask everybody, we've made our point known, but let's actually request the training from OMH so we can see it. And then we'll be responding to something that exists as opposed to we don't know exactly what the content is.
Yeah, fair enough. And we can have a continuing dialogue on that. Happy to.
Before we go to Mike Noble, and I let him know we're coming to him. I did have the other questions that I wanted to ask. There's 4 of them, Brian. Clinical support line for NYPD, is that 24/7? The second thing is, if you could just answer these briefly, I would love if we could end before 8:30. Okay. What brings you to this work? What drove the policy? You mentioned it and I missed it. And then Joe basically asked about this, but I did write down, and he talks about supportive housing changes, such as an increased level of care when someone's mental health issues surpass the capacity of the staff.
Right. Yeah. Okay. So I think the 4th one we have talked about, right?
Yeah, we did.
Right. So what was the first one? Sorry.
The clinicians who answer the calls for the NYPD, is that 24/7?
Yes, it is.
Okay. And then what brings you to the work and what drove the policy?
Yeah. So what brings me to the work I think I mentioned that it was about 25 years ago now. I was just a little bit out of law school, and I was just joined the Attorney General's office here in New York City. And we had an incident where Kendra Webdale was pushed into the path of an oncoming train by a man named Andrew Goldstein, who was, very well known to the public mental health system. It was not shocking to many people who had worked with him over the years that he had been involved in such a tragic incident. And I was asked by the Attorney General at the time to figure out what kind of flaws and gaps in New York law made it possible for somebody, in that condition to be kind of roaming the city, unmedicated, unmonitored, without any kind of support. And, at that time, I became aware of this concept of assisted outpatient treatment, AOT, that we talked about, and the fact that there were at that point 30 states that had such laws on the books. And I became connected to an organization called the Treatment Advocacy Center that helped me in drafting what became Kendra's Law. And, I was kind of taken aback at the time by how controversial the proposal was. I kind of, in my young naivete, assumed that we would kind of be universally applauded by putting this proposal out. And I was really kind of just, kind of struck by what I thought was just how people had so missed the point in terms of how we actually respect the rights and the needs of people with severe mental illness, to be so focused on, their independence in decision-making, rather than the opportunity that they had to actually get treatment and keep them in the community, keep them out of jail, keep them out of hospitals in a way that they actually could meaningfully exercise some kind of freedom. I just think that just kind of the controversy around it at the time kind of bonded me kind of emotionally to the issue in a way that anything else I did in the years that followed that just kind of never meant as much to me. And so, an opportunity arose about 10 years after that to go to work for the Treatment Advocacy Center, move down to DC and kind of take on this issue full time as a national advocate. And I jumped at that, and it's kind of been my life's work ever since. And as far as what drove this particular policy, I think it was, when I kind of came into the administration, and when it was in very much learning mode initially, and was out with some of the teams that we have doing end of line work and tagged along with some mobile crisis outreach teams around the city, saw something that, the mayor himself has seen in his own kind of observations of this work, which is that we do sometimes walk away from people who are in psychiatric crisis because of the fact that we have folks who hadn't been understanding the law as it actually existed due to case law. And so that I think was the driving force behind this particular approach, that making sure that that our implementation of the law was well informed by what the law actually allows us to do.
Thank you so much. I'm going to bring Mike Noble over.
I brought him. I just pressed to bring him over. I don't know if Nellie did it before I did, but he's coming.
There we go.
Hi, Mike. You're here.
Okay, thank you. Hello there, Brian. Two things. Getting back to the initial question that JD brought up, the example with the fellow on the street with ulcers on his feet and all that business, right? And you said that this case where this fellow might want to just decline medical attention. I think what you're saying there is, if the fellow has not displayed some sort of mental illness, some symptom of mental illness, then you can't get past that.
Correct.
Right? And
correct.
Okay, so we start with that foundation.
Yep.
Fellows, to me, if you are sitting on the sidewalk with ulcers that could result in your amputation of your feet, that is a per se, to me, indication of mental illness, be that as it may. I think when people evaluate cops, whoever they might be, evaluate someone like that, it is all subjective. So you're going to have different outcomes depending on who it is that arrives at the scene. So that's just for openers, right? So that's one thing. That's just my own. I just want to clear that up in my own head. I don't know if you're aware of this. There is a policy in the public school system that allows kids to be transported for evaluation. And you're aware of this, now?
Yeah.
Yeah, okay. So I thought this was, outdated, outmoded, banned for that. And I read this article in the City newsletter, I think it was today, that there are thousands of these kids who are being what they call EMS'd. And what that means, right? What that means is a teacher who's having a problem with a kid, depending on what's in that teacher's mind, can say, I want to call the police, have them take this kid to a hospital for mental health evaluation, right? We'll give the parent a chance to come up here and take the kid out of school first. But if they don't arrive in time, well, then the kid's off into an ambulance, off to the hospital. I was shocked by that, shocked by it. And you see the irony here. You got somebody on the street who was clearly in need of evaluation, who can't be taken there. And now you've got someone who is not, trained or whatever, a teacher, for God's sake, a teacher, who's ticked off at the kid, right? And calls cops on him, right?
Yeah.
And the reason I bring it up, my son has always been a handful. When he was in junior high school, he was in a place where he refused to take his baseball hat off in class. And after repeated requests, he said, no, he just said, no, I'm not going to do it. Teacher called the cops. He was EMS. I got up there. I from Manhattan, it took me too long to get there. And I had to go into the hospital, into the psychiatric emergency room, and sit down there with psychiatrists. Yeah, right. Psychiatrist who's interrogating my son with the most abhorrent questions, traumatic questions, right?
All over a refusal to take off a baseball cap.
Exactly. And
incredible.
So, that in and of itself was traumatic. Should not have happened, right? And like I said, I was just, it's just flabbergasted. I said, this can't still be, and this happened like, geez, over 20 years ago, Even at the time, it was like, this is outrageous. Pulled me out of work because the kid wouldn't take his bloody hat off. And I told his teacher, I said, look, just take the thing away from, take his hat off yourself, for God's sakes. You got my approach, just take the hat off the kid. As being defiant,
Yeah.
So anyway, my question is, do you folks, you in particular, do you get involved with this? I mean,
certainly the school issue that you're raising is beyond anything I would ever be involved in. So it's just kind of outside the scope of what I work on. I mean, it's pretty shocking what you're describing. I cannot believe that that protocols were followed, and that the teacher made that decision was acting according to the training that they received on how to exercise that authority. I can tell you with respect to the police authority that you kind of started with, that if they follow the training that we give, and of course there's always some possibility the police officer will act contrary to their training. I cannot possibly rule out that could happen, but the subjectivity that you're suggesting as part of the process is really something we try and rule out through the training, right? Because we're not asking an officer to give their opinion as to whether someone would have to be mentally ill to be willing to live with this particular medical condition, right? We are saying to the officer, you have to observe legitimate symptoms of mental illness, such as hallucinations, delusions, catatonia, disordered speech, right? We're talking about specific symptoms of mental illness. And in the absence of observing any of those, an officer who was following the training would not have the authority to say, as far as I'm concerned, anyone who doesn't want to get help for this problem must be crazy. It wouldn't be appropriate.
And I really think that the issue of the ulcerated feet, which is a good way to use, more people are exhibiting other behaviors at the same time.
Yeah.
And we see that across our neighborhood. We see that throughout our public facilities. It is not
Exactly.
an isolated case. And so I think it's everything done in conjunction. And what you've helped us tonight is to realize it's not sort of an either or, it's a number of factors coming together. And for us tonight, we will not be taking any position or responding tonight because we want to get all these documents and information so we can have a full discussion at our June committee meeting about this, I think, and
Okay.
continue in July, because I don't think the legislative action is happening, but
No, I
certainly
agree.
the more we get engaged with it, because we've been very focused on this for a couple of years, the better. And then we can give a more nuanced position. Dolores, you'll have the last word on this one.
Oh, wait, before it's
It's just a question. It
Oh,
isn't,
okay.
you have the last word, Maria. It's your committee.
Okay.
Brian, earlier you mentioned that some of the pilot areas where the program is at the moment in Manhattan. You mentioned specifically, I believe, Penn Station and Grand Central.
The teams, the joint response engagement teams. Yes.
Yes.
Correct.
What about Port Authority? I know that that's a multi-agency place, but we do recognize that that has always been a location where we have folks that will shelter.
Yeah, I think that that's a pretty good guess as to where we would expand next as we enlarge that particular approach.
Yeah, thank you so much, because obviously those two stations are multi-jurisdictional and so is the port, but we know they all work together in terms of difficulty and people seeking shelter. Thank you very, very much, Brian. Expect to hear a lot of information from us, and we really appreciate your coming to us with a nuanced, presentation. Really
appreciate that. Thank you, and
Brian,
I'm grateful for the forum.
Yes, I'm glad I got to meet you 2 weeks ago. That was because of Jerry.
Yeah.
I'm going to send you the letter that we did, CB4, related to the mental health forum that we did last week.
Sure.
And I'll send that over when it's final.
That sounds
Thank you so much for being here.
Oh, my great pleasure. And if, you could just put in the email everything that I promised to include in my reply, so I don't forget anything. I'll get it all back to you.
These meetings are recorded. That's the reason.
Oh, perfect.
Yeah.
Joe, Maria, are you sure there's no letter to come out of this meeting? I mean, we had a huge letter come out of a mental health forum. At least some thank you.
I really think we want to acknowledge his attendance and maybe recap some of the things that were said. But as for positions, we need more time to engage with this. So
I agree, but at least let's memorize this.
So then, JD, you want to make a motion that will it'll be thanking and sort of acknowledging to Brian for this.
Sure, I make a motion that we thoroughly thank Brian for this splendid presentation and timely one, and for addressing our questions so thoroughly, and that we look forward to hearing more about this and to learning more and to contributing to developing this program so it benefits not just the community, but especially those who may be suffering or those who may be dealing with the issues of mental health.
Second.
All those in favor, please raise your hand. Okay, and we will have time to write this letter because we have more time.
Thank you all so much. Great to meet
Thank you, Brian.
All right.
So,
have a great night, everybody.
Thank you. During the course of this meeting, I received an important text from our council.
Wait a minute. Who's helping me write this letter? Any volunteers?
I will certainly work. I will work on it with Maria. I will work on it.
I see
JD raised his hand. Thank you, JD.
I'll raise it.
All right. I'm writing that down. JD is helping.
So
Okay.
Moving on to a piece of new business which came out of the air during the course of our meeting. From our council member, we have another hotel opening.
Drop off. Take care, everyone.
I can't even tell you. Another hotel opening. Here is what he knows so far. This is from the mayor's office. Due to the increase in number of asylum seekers coming into the city, we're averaging over 500 per day again. We need to open an additional emergency hotels. We'll be opening Casa Mia at 449 West 36th Street. We're using 39 rooms for families with children. We will likely be opening today And the provider will temporarily be DHS staff. We know that's a recipe for success until we can get a more traditional provider at this facility. I mean, I think we've averaged, is it one every 3 to 4 weeks or 4, weeks?
Joe, what's the address again?
449 West 36. That's on the north side of 36 between Dyer and 10th. It is, again, at least it is not a location that is got a lot of, arrests and things happening around it. That's helpful. So it's not as bad.
Well,
But-
we better let Brian Weber know.
Yeah, but we should also be aware that it is the location that is physically challenging to get to. You must cross 6 lanes of Dyer Avenue to get this. Imagine you are coming from another country. And
I'm sorry, where is that between Dyer and?
Dyer and 10th. It's on the north side of the street. A small budget hotel.
Maria, it's where that curvy part happens at Dyer. There's
Mhm.
like extra lanes out of nowhere.
Yeah, but
Why would they? I'm just so
you
frustrated.
you cross the regular part of Dyer, but then you have to cross the lanes that bring you down to 30th Street.
Yeah.
And you don't realize that it's very oddly signaled.
Yeah.
So cars you have to really understand this location, know how to cross. So listen, here we are again. So we will invite DHS to a meeting to discuss this. And I understand the need, obviously, but I wish this was being run by HHC and not DHS, because we're now to the same thing of the provider. Maybe, let me just poll the committee. Do we think we should maybe even put out that ask? Because we know it's going to be run better than DHS, because we know the difference between the Watson versus some of the other, the Watson and the Roe. What do people think about it?
Yes, I agree with that decision, because these families, it's just so frustrating. You have DHS, they're already like, they're overflowing with people, and they cannot serve the folks that they already have, the families that they have.
Yeah, Katie, then Roberta.
This is news to me tonight that the asylum seeker arrivals have gone up to such a level of 500 a day. And
Well,
I know that
It's news to all of us.
Yeah, I don't know if we can really rely upon it so much, Katie. This is what the mayor's office reported to the council members.
Right. So frankly, that's something that I would actually like us to ask somebody to come speak to us about, so that we can hear what's happening. I mean, I'd read sort of nationally that they're expecting things now in the warmer weather.
Right, going forward. Right.
So it doesn't surprise me that it's going to be happening. I guess I hadn't realized it was starting already. So I think it would be great if we could get somebody from somewhere in the mayor's office to come speak to us about that. And I will say, my understanding is that many of the shelters that have opened for the asylum seekers don't have any providers appointed to run them yet, because they don't. They're trying to find them and they're not finding them. So anyway, it's a lovely idea to ask, can't HHC come do this? But I think they would be delighted if they could. But I think everybody is saying that they're sort of tapped out, which is why they were reaching out of state and other places to try and find providers. So anyway,
they're reaching out of state for providers?
That's what I'd heard. Again, I don't know all the details, but that is what I'd heard, because that's why, they're
But that's a
National
recipe
Guard
for
at some of these places right now, is because they just don't have. They're asking all the traditional providers. This is the whole, it's the whole much bigger picture. There just aren't enough people to be able to provide all the services that are needed in the city right now.
Right. Yeah, right. Even if there were providers, they could not get the actual staff to staff the locations, period.
Yeah. And I know, I know that there are asking the traditional providers, and the providers are saying, we're already understaffed at the facilities we're already running. We can't take on new ones. So to be honest with you, I think it's a more effective position from us if we say, we love from what we know of how HHC has been able to run these places. And so if they or some other provider using that model could run this, that would be great, because we think,
the model HHC is based upon running a facility. It is not a model. It's how they run hospitals. right? So that's
Yeah, but we can say like,
here.
here are why we think that the way they run it is great and we'd love to see this implemented. Anyway, I think if HHC could do it, they would do it, but
I don't know if they've been, I don't think decisions are made any sort of thoughtful. I don't think these decisions are made on the spot. And I do not believe that. I think it's that we can ask, can we have a different model to run it? That's all. I think that's not an crazy thing to do at all.
yeah. And just real quickly, I would also be really curious. I mean, because we always, we feel reactive because we find out about things at the last minute. But as we know, under this emergency order, everybody seems to be finding out about the last minute, including, DHS and everybody. So I guess I'm curious. So, all right, we've heard that there are 500 people coming in. I'd love to find out, and where else have they been opening them? And
right, but I'd like to focus us. We have a new facility being opened. Do we want to react or not? So let's come back to you in a second. Go to Roberta. What are your thoughts about what we should action take or not?
So generally supportive of the action. I did want to ask if we did feel that HHC was an appropriate provider. The only reason I am asking is because typically HHC's mandate is medically vulnerable. I know that that's sort of shifted. I was wondering if you had any thoughts.
Yeah. They're operating the Hercs in the 2 locations, and they've actually they have now. If you remember, Watson went from singles to families, and we have had very few complaints about their management of it and their running of it. And if we have the families housed there, maybe, it's trying to figure out a way that we can have less impact from a bad management point of view. That's all.
No, I think
So no.
Yes.
But the other thing is that you don't have to have it doesn't have to be due to.
It doesn't have to be medical.
Right. It doesn't have to be medical.
Okay. That's helpful clarification. Super generally supportive of that. I think one of the best things this committee can do is to advocate for better, social services management. I think that it's the management of social services that typically dictates whether or not will be sort of a nuisance to the other members of the community. I also want to just separately echo the request that Katie made for some sort of briefing, because as the Title 42 ends, I know the Biden administration has engaged in some sort of agreement, and that's likely, it's supposedly supposed to impact the number of people who will arrive in New York City, asylum seekers, and could increase that number. And it would be helpful, I think, to hear from city officials what they anticipate, because if that does happen, my guess is that they would likely want to open even more facilities, which I think that the community would like to have a better understanding of that, not myself, but other folks as well.
I think we should invite them back. They spoke to us briefly, like 2 or 3 months ago. So let's ask them to come back.
Who's them? Ask who to come back?
It's the mayor's office. Sabrina, what is the exact name? I forget.
It's MOA, I believe. It's immigration office.
Yes, it's got a.
Yeah. MOA, and mayor's office for the immigration affairs or something like that.
Thank
you. Yeah, and they spoke to us at one meeting. Like, we can just sort of say, come and give us an idea of what what is the issue, how is it being presented, what do you expect, what are you preparing? Because the last thing in the world we want is let's have here's 17 more hotels in one location.
Can I add to that?
Oh yeah, please, yeah.
Because just on the budget side of it, because the projections are coming more asylum seekers, and they're like $4 billion they're added into the budget now, an exec budget. But that's just public information, but I'm also curious to know, because I don't know if MOA should know and have the facts about what's the projection of the folks that were coming in. And again, that's based on what is projecting on the budget. But the policy nationwide is very different. Like Title 40, yeah, it's true that it's coming down, but now there are treaties with Mexico, for example, to deport folks back to Mexico from the US if they are from countries like Venezuela, Guatemala, and Cuba, where they can apply, they need to apply from there, and they need to apply from the technological perspective. So there's a lot of Obviously, we don't know, but my understanding is that they actually won't let folks enter the border in the same way, just as Article 2 strikes down. So I think, it'd be great if we can actually find somebody more. I mean, again, MOA, again, they should know, but again, they're projecting more people, but I don't know if that's really communicated with like the federal policy itself. Also, these are just, we don't really know what's going to happen until it happens, but I can tell you that, that like, these are like the things that like, there are different laws and policies that have been implemented on immigration, and I follow immigration very closely. So that's why I know. It'd be helpful, again, maybe have MOA, but have somebody, I don't know what capacity we can know on the federal level. I don't know if it's possible or not, but I think there might be two different sides of it, just because the mayor's, the projection is very high for folks who are coming in, but that doesn't really make sense on base what the Biden administration is saying now.
Right. They may not have the full information as to how things get applied.
And that's,
you don't know. Right. JD, then Katie.
My concern is this is a terrible place to put children and families. And I think we have asked in the past that before they do this, they explore the schools, the parks, the supermarkets with us so we can help these families. And I think it's very important that we emphasize that continue. That's a terrible place to put kids.
Well, it's just tantamount to the same issue we had with the shelter on 41st Street, that you have to figure things out in advance, right? Like we have the 41st, we have a contra bus lane running against the traffic during evening rush hour. That wasn't thought about at all. How do you manage that, right? Here's a little bit different. I think there are a lot of families who live around there, JD, but the coming back and forth from the 9th Avenue side versus 10th is a big issue. That's a huge thing to cross. Hector, then I'll go to Katie, because Hector hasn't spoken yet.
Yeah, I'm very concerned about the location as well. That is a really high traffic area. I mean, there's a lot of tunnel traffic coming from there, along with the local streets. I think at the least, if they're stuck with that location, there should be some allowances made, maybe possibly a crossing guard or something assigned to that specific location.
Right.
I know, because honestly, something's going to happen there. That's a very bad location. I travel through there quite frequently, and I'm constantly seeing tourists trying to get across, and they don't know any better.
They get marooned because they don't know how the signals work.
Exactly. So, I mean, at the least, we should make some express the safety concerns on this to make sure, hopefully, nothing happens.
Katie.
Thanks. I was just going to say, if we do invite somebody from MAW or whatever it's called to come speak, which I think would be a good idea, I think it would be great to also ask them if they're the right person. We had talked a couple months ago about advocating or requesting like a centralized person in the mayor's office to deal with asylum issues. Because it seems, it's all just so disparate, like, oh, not us, they're doing that. Oh, not us, they're doing that.
You got that right, Katie.
And so I think that it would be great for us to sort of revisit what we had talked about a little bit a couple months ago, which is asking for a sort of centralized place in the mayor's office to coordinate these efforts. So then maybe we could all be a little more better informed and stuff. And then just separately, Hector, I think it's a great idea if we advocated for a crossing guard there. So thanks.
I wanted to do this for a moment and go back here just so people get an idea of where we are. Please note, this is what you have to cross to get there. 1, 2, and then cars are going not only across the street, they're going down to 30th Street too. So this is quite that's a long intersection for children to cross.
That's not good.
And the hotel is down the block. Right over here. So that is quite a way to get to your home. You should just be thoughtful about that. Any further? I'm sorry to bring this up at the last minute. Obviously, I just think what we'll do is have Jesse, of course, invite DHS to come and talk to us about it. But it gives you an idea of the dynamic that we deal with DHS, that we could be sitting in a committee and the council member gets told today that it's opening today. Somebody had to know at some point earlier this week that it was opening, and at least there could have been some discussion about this with the very things we just talked about, like a crossing guard or things like that. Anything else, Maria, new for tonight?
No, there is nothing else.
Is there a motion to adjourn from anyone? From Travis? No, he's raising their hand.
Motion to adjourn from all of us.
But I want to say thank everybody. I think we really had a serious, full presentation tonight that really helps us think and understand these things.
Well, Joe, that was the best presentation that I've witnessed since being on Target.
Yeah.
Excellent.
Thanks so much, guys. Good night.
You're welcome. You're welcome.